minutes. It's a big presentation, so I request Dr. Yasir to go through it in a matter that it finishes in time. Dr. Yasir Khebar is Chief Resident at Liaquat National Hospital, and he will be presenting today the anatomical and radiological approaches to the frontal lobe, and he will also show you some scans and will show radiological localization according to the lobar anatomy. Yasir, do you think we should start?
Yes, sir, we can start.
So, Yasir, why don't you go ahead and start? If we have time in the end, we will take questions, and I expect people to drop their questions in the comment box, or if there's any query that they can raise your hand. Dr. Yasir Khebar, please.
Yes, sir. So today we are going to discuss clinical.
Yeah, so you need to speak up. Your voice is, you need to just sit close to the laptop maybe.
Okay. Today we are going to discuss regarding the clinical neuroanatomy. We are going to be dealing with the cerebral anatomy itself. So we have divided into various portions. Today we are addressing the anatomical and the radiological approach to the frontal lobe. So I'm Dr. Yasir Khebar, Neurosurgery from Liaquat National Hospital.
Yasir, they cannot hear you. You need to either you need to sit very close to the laptop, or maybe use a headphones if possible.
Can you hear me now, sir?
Yeah, it's better. It's better.
Okay. So when we are talking about the anatomy of the cerebral hemisphere, we know that within the anatomy of the cerebral hemisphere, we have got three surfaces that we commonly deal with. Surfaces are the lateral surface, as you can all appreciate in this picture. We have got the inferior surface or the basal surface, and the third surface is the medial surface that we are going to be dealing with. So there are three surfaces: the basal surface, the lateral surface, and the medial surface. Regarding the three margins that we'll be discussing, we have got a superior margin, we have got a medial margin, and then we've got a lateral margin. Within the three poles, we have got the anterior pole, as all of you can appreciate, this is the anterior pole or the frontal pole. Then we have got a temporal pole, and posteriorly, we have got this occipital pole. If we talk about various lobes that we've got the four conventional lobes, that is the frontal, temporal, parietal, and occipital. And the fifth lobe is basically the central lobe, which is sometimes classified as a separate lobe. I will go through it in detail when we are discussing. We have got three types of white matter fibers within the cerebral hemisphere. They are the commissural fibers, the association, and the projection fibers. And then in the midline, we've got a longitudinal fissure within which lies the falx cerebri. And we've got a very important feature. So these are the main headlines or main things we will be going through, and we will be discussing about them specifically.
Dr. Yasir, I'm sorry, but you need to sit close because you kind of drops and your voice kind of drops in between. So you have to make an effort.
Can you guys hear me now?
Yes, it's better. Keep it this way.
Okay. So all of you can appreciate the lateral. All of you can appreciate the lateral surface of the cerebral hemisphere over here. Within this surface, you can appreciate the frontal lobe superiorly, and we have got the temporal lobe inferiorly. And in the posterior region, we've got the parietal and the occipital lobes. Within the frontal lobe, you can see that frontal lobe is divided or separated from the parietal lobe by this sulcus that is running on its surface. This sulcus is known as the central sulcus. So all the part of the brain that is anterior to this central sulcus is a part of the frontal lobe, whereas part of the brain that is posterior to it is the parietal lobe. And then we've got another sulcus over here that runs on the surface. This is known as the Sylvian fissure or the Sylvian sulcus. This is not a simple sulcus that runs on its surface, but actually it's a deep cistern and has got various parts. In the next sessions, when we discuss regarding the sylvian fissure anatomy, we will deal with in detail. And it divides or separates the frontal lobe and the parietal lobe superiorly from the temporal lobe inferiorly. Then on the lateral surface, the occipital lobe is separated from the parietal lobe via an imaginary line. This imaginary line is actually drawn from this point. This is known as the intraparietal sulcus. So this intraparietal sulcus, sorry, this parieto-occipital sulcus. This parieto-occipital sulcus is a sulcus that runs on the medial surface, has just got a slight extension on the lateral surface. If we draw a straight line from this parieto-occipital sulcus to the occipital notch inferiorly, this imaginary line actually separates the occipital lobe on the lateral surface from the parietal lobe. So moving on to the next surface, this is the anterior view. From the anterior, we can appreciate the frontal pole of the frontal lobe of the brain. We can appreciate the temporal lobe and the temporal pole as well. We can see that frontal lobe is divided into various gyri. It can be superior frontal gyrus, it can be middle and inferior frontal gyrus. If we are going to go in detail later on. In the midline, this is a cleft that's known as the longitudinal cerebral hemisphere or interhemispheric fissure. Within this cleft normally runs the fold of the dura that is shape, and because of its shape like a sickle, it's known as falx. So this is the falx region where the falx cerebri runs, and superiorly we have got the superior sagittal sinus running over here. This is the view of the cerebral hemisphere from a superior aspect. You can appreciate the frontal lobe anteriorly, occipital lobe posteriorly, and you can see the superior view here. You can appreciate various gyri of the frontal lobe as well as the parietal lobe. This is the posterior view of the same picture. In this, the occipital pole can be appreciated and a large part of the occipital lobe can be appreciated. Within this picture, again, you can appreciate that this is the posterior parieto-occipital sulcus, which actually separates the parietal lobe anteriorly from the occipital lobe posteriorly. Now, this picture shows the basal or the inferior surface of the cerebral hemisphere. Today, we will be discussing this part of the basal surface in detail, that is the frontal lobe. The temporal lobe and the occipital lobe also share the basal surface along with the frontal lobe, but we will address them later on. This is a part of the temporal lobe on the basal surface. Posteriorly, we have got the occipital basal surface. Now, this is the medial surface of the cerebral hemispheres. Here you can appreciate the frontal lobe extending and the parietal lobe extending on the medial surface. Parieto-occipital sulcus is the sulcus which predominantly lies on the medial aspect. So this is the parieto-occipital sulcus, and behind it is the occiput. Anterior to it is the parietal lobe, and this is the temporal lobe on the medial surface. So you can see that the frontal, temporal, and the occipital lobe have got a big contribution on the medial surface. Okay, now coming on to deal with the anatomy of the frontal lobe in detail, all of you can appreciate this picture. In this picture, we can see that this is the orbit and this is the roof of the orbit. So the frontal lobe actually rests on the roof of the orbit within the anterior cranial fossa. And this frontal lobe has got various boundaries. We have got the floor of the anterior cranial fossa. We have got the superior border. On the superior border, we have got the superior sagittal sinus running. And the posterior boundary is by this fissure. We already discussed about this fissure. This fissure is the central sulcus. Now, how do you identify the central sulcus? Now, this green highlighted structure is the central sulcus. One point that aids in the identification of the central sulcus is that you can see that it does not open all the way within this another sulcus that is located on the lateral surface. This sulcus, as I already told you, is the sylvian sulcus. So the central sulcus starts from the top on the lateral surface, but a gyral bridge actually prevents the central sulcus from opening directly within the central sylvian fissure. This gyral bridge is known as the subcentral gyrus. So the subcentral gyrus in a majority of the population does not allow central sulcus to open directly within the sylvian fissure. Now, the part anterior to the central sulcus, this gyrus that lies just anterior to the central sulcus, is the precentral gyrus, and it's obviously the part of the frontal lobe. And then this sulcus, which lies anterior to this precentral gyrus, is the precentral sulcus. And the gyrus posterior to the central sulcus is the postcentral gyrus, and this sulcus is the postcentral sulcus. Both these areas are important because these areas actually represent our primary motor area within the precentral sulcus and our primary somatosensory area within the postcentral sulcus. Now, this sulcus that has been highlighted is actually the Sylvian fissure or the Sylvian sulcus on the lateral surface. As I told you guys previously, this is not a simple sulcus that is located on the surface of the cerebral hemisphere, but actually it's a deep cleft. And if we retract these parts of brain, like if we retract this temporal lobe inferiorly and we retract this part of the frontal lobe superiorly, we can see that there's a Sylvian cistern or a Sylvian cavity that also runs on the medial aspect of the brain and goes all the way till the opticocarotid recess along the lesser wing of the sphenoid. This approach we usually use when we are approaching the various aneurysms within the skull base region. We go through this transsylvian approach. On the surface, also, this is not a simple fissure. It has got a posterior limb or the posterior ramus. This is the posterior ramus of the Sylvian fissure. And then it has got various anterior projections. So can you see my arrow? I'm tracing this projection of the Sylvian fissure. This projection is known as the anterior horizontal ramus. And another projection like this one is the anterior ascending ramus. So in between the anterior horizontal and the anterior ascending ramus, we've got this part of this gyrus that is triangular shape. Because of its triangular shape, it's called pars triangularis. And then this part that is anterior to the pars triangularis and is lying on the roof of the orbit is known as pars orbitalis because it lies just over the roof of the orbit. And then posterior to this triangle shape, this part that actually forms a lid or covering over the Sylvian fissure is known as pars opercularis. So we've got pars orbitalis, pars triangularis, and pars opercularis. And these three together make up a part of the frontal lobe that is known as the inferior frontal gyrus. So the two limbs of the Sylvian fissure, the anterior ascending and the anterior horizontal ramus, divide the inferior frontal gyrus into three parts: orbitalis, triangularis, opercularis. Now, other divisions of the frontal lobe are by various sulci that I'm going to show you. In this picture, the precentral sulcus has been highlighted. So the precentral sulcus separates the precentral gyrus from the anterior part of the frontal lobe. This is the postcentral sulcus being highlighted in this picture. So you can see that the postcentral sulcus actually lies within the parietal lobe, and anterior to it, this gyrus is your postcentral gyrus. Now, this is the part anterior to the precentral gyrus. Here we have three main gyri of the frontal lobe. We have got a superior frontal gyrus, we've got a middle frontal gyrus, and then the inferior frontal gyrus we already discussed. These gyri are separated by two sulci that are running horizontally. One of them is the superior frontal sulcus, which separates the superior from middle frontal gyrus, and the other one is the inferior frontal sulcus, which divides the middle frontal gyrus from the inferior frontal gyrus. This is the part of the parietal lobe that has been highlighted. I'm not going into detail for today. So this is the superior frontal gyrus highlighted for you guys. Beneath it, this portion is the middle frontal gyrus of the frontal lobe. And this is the inferior frontal gyrus. We already discussed three parts of it. The posterior two parts in this region, the pars triangularis and pars opercularis, are important with respect to an area that is localized over here in the dominant hemisphere. Broca's area, which controls the motor part of our speech, is usually located within a part of the pars triangularis and within the pars opercularis. So if we are operating on any lesion with this area, this is an eloquent area and can result into the motor aphasia of the patient. So this is the precentral gyrus highlighted, which is a part of the primary motor cortex. Postcentral gyrus, the primary somatosensory area. And this concept I already told you, that the central sulcus does not open all the way to the sylvian fissure, but rather there's a bridge of the gyrus, that is subcentral gyrus, which prevents it from opening all the way. This point can also be used intraoperatively when we have a limited frontotemporal craniotomy exposure. Within this region, we can identify the central sulcus in most of the cases. There are some variations where it would be opening, but in most cases, we can identify by this gyral bridge, which actually prevents the central sulcus from opening within the sylvian fissure. So that's how you can localize intraoperatively that which part is the motor area, which is just anterior to it. Now, this is a picture taken from the Greenberg, which shows the concept of the Taylor-Horton line. There's a line drawn over here from the nasion till the inion. This is the naso-inion line. And on the naso-inion line, we have marked the one half of the naso-inion line. So what I'm going to describe over here is how to localize the central sulcus or the precentral gyrus with the help of these lines. So if you mark the one half of this naso-inion line, just 2 centimeters behind it is the region where the central sulcus usually lie. So there are 4 methods. One method is you just go straight up from the external auditory meatus. The other method is you mark this point, which is 2 centimeters behind the naso-inion line, and join it with another line that is drawn from the mid of the condyle of the mandible. This is the condylar line. And join these 2 points together where this line bisects the sylvian fissure line. How can we mark the sylvian fissure during a craniotomy? We have to take the mid of the lateral margin of the orbit and take it all the way back to the 3/4 quarters of the naso-inion line. That will be your sylvian fissure. So these are the 2 methods. The third method is that you can draw a line at a 45 degree to the reed space line. The reed space line goes from inferior margin of orbit to the mid of the external auditory meatus, and a line drawn at 45 degree points straight in the direction of your motor cortex. Another method is via the coronal suture. The motor cortex is located approximately 4 to 5.4 centimeters behind your coronal suture. So this picture highlights the concept of the central lobe that I already described. The precentral gyrus together with the postcentral gyrus make up the central lobe. And this even continues on the medial surface. So this is the continuation of the precentral gyrus on the medial surface, but you can appreciate the central sulcus does not run all the way on the medial surface. There's a slight extension of the central surface on the superior aspect of medial surface, but not all the way. So the paracentral lobule again has got both motor and somatosensory areas on the medial surface as well. This is the anatomical representation of a complete man on the lateral surface of the hemisphere. In Latin, the little man will be named as homunculus. The homunculus word means simply a little man that is running all over the surface of the hemisphere. So this is the primary motor cortex where the somatotopic representation of entire body is located. You can see that for the fine control, we have got a larger somatotopic representation. Like for the hand, just in the middle region, we have got a large representation for thumb, index. This provides the fine control to these structures because a large part of the cerebral cortex pyramidal cells is dedicated to this specific area, whereas for the trunk, we've got a slight smaller portion. Also to note over here is the location of our lower limb and the genitalia. The lower limb and genitalia control is usually on the medial surface or in the paracentral lobule of the homunculus. So if there's a lesion in this region, your contralateral lower extremity would be affected. If a region in the lower part, your facial weakness can be there. And in the mid portion, you can have the loss of the hand movement or hand control. Similarly, within the primary somatosensory cortex, within the postcentral gyrus, we have a similar homunculus representation. Now, this very important area that is just anterior to your precentral gyrus is premotor area. This is also a part of your middle and inferior frontal gyrus, but if in another classification with the Broadband area concept, this area is the premotor area just lying anterior to your primary motor cortex. This premotor area is also known as the supplementary motor area. This is the area where the programming of the motor activities takes place. So how we are going to perform in a specific activity, like one muscle is going to flex, the other one is going to extend. This all programming takes place within this Broadband area 6 or the premotor area. Also, recently we came to know that there are speech areas located on the dominant side within this premotor area as well. So if your premotor area is involved, your speech may be affected. We will be going to in this detail on later on in our lecture. So this is the part of the parietal lobe. We are not discussing it today. This is the supramarginal gyrus that we will discuss later on. So again, this picture is showing the concept of subcentral gyrus. The other parts we have discussed in detail. In this picture, we have actually dissected the superior and the middle infrontal gyrus. You can see that superior, middle infrontal gyrus have been dissected out. Inferior frontal gyrus has been left intact. What this picture depicts is a relationship of the more superficial lateral surface with the deep medial surface. You can see the inferior frontal sulcus just lies at the level of the inferior margin of the corpus callosum. So on superiorly, where the inferior frontal sulcus is running, this is the area where the corpus callosum is actually ending in the medial aspect. And the cingulate sulcus actually runs in the region of the superior frontal sulcus. So this is a correlation between how your superficial structures are correlated to the medial structures which are located deep to them. Within this picture, further dissection has been done. Even the inferior frontal gyrus has been removed. The pre and post central gyrus have been left intact. And you can appreciate the ventricles and how they are related. We can see the corpus callosum. We can appreciate the septum pellucidum running in between. This is a sheet which divides the lateral ventricles. We can appreciate the level of foramen of Monro. The level of foramen of Monro is important because it usually lies just at the apex of the pars triangularis, where the apex of pars triangularis is pointing. And with the reference to the insula, the foramen of Monro is usually located at the midpoint of the second short insular gyrus. Again, corpus callosum and cingulum can be seen. We will be discussing these structures in detail when we deal with the medial surface of the hemisphere. The shiny false cerebri that is running in the intrahemispheric fissure can be appreciated. So again, the frontal lobe has been highlighted for you with the various venous structures. You can see that the various cortical veins on the surface drain within the superior sagittal sinus. This is the parietal lobe. Both are separated by the central sulcus in between. Again, this is the picture that has been taken from the front. When we are looking from the front, this is the frontal pole. You can see that here the arrangement is like this one is the superior frontal gyrus, this one would be middle frontal gyrus, and finally over here we would be having the inferior frontal gyrus. Also, you can see the superior sagittal sinus, and along both sides of the sinus, we have large dilated venous channels that are known as the lacunae. Sometimes when we are operating from the top, we're doing a frontal craniotomy. These lacunae can hinder our access when we are going for an intrahemispheric approach. So usually we have to take an area that is around the corners, which area is relatively free of these lacunae. So this is the posterior view, not going into detail, but another important structure that has been shown over here is the tortuda heteroflagellum. This is the region of the confluence of sinuses. You can see the superior sagittal sinus is joining with both transverse sinuses from the two sides. Also here we have the internal occipital sinus that we cannot appreciate in this picture, and the straight sinus that cannot be appreciated in this picture. This point is known as the confluence of sinuses, and on external landmarks it corresponds with the external occipital protuberance. Now coming on to the medial hemispheric surface, more specifically the medial hemispheric surface of the frontal lobe. We already studied in detail how the frontal lobe is separated from the parietal lobe on a lateral surface, but how it is separated on a medial surface. That's what we are going to discuss now. You can appreciate that the medial surface is not as simple. It is actually made up of various layers of the brain. The innermost layer is of the corpus callosum. So this structure, this white structure in the midline, is the corpus callosum. Just overlying the corpus callosum is another gyral layer that is known as the cingulate gyrus. So the second layer is of the cingulate gyrus, and the third layer is actually the continuation of the lateral surface on the medial surface. So this layer is of the superior frontal gyrus, which is continued from the lateral surface onto the medial surface. So we have got three layers. The corpus callosum and the cingulate gyrus are separated by a sulcus that is known as callosal sulcus. Whereas the cingulate gyrus and the superior frontal gyrus are separated by another important sulcus known as the cingulate sulcus being traced by my arrow. How do we differentiate the frontal lobe from the parietal lobe on this aspect? You can see the paracentral lobule, which is a continuation of pre and post central gyrus on the medial surface. I already told you that there is a small portion of the central sulcus that comes onto this surface. This portion of the central sulcus can be traced straight to the corpus callosum, and this will actually mark the boundary between the frontal lobe anteriorly and the parietal lobe posteriorly. So just anterior to this point, all this part is the frontal lobe. So we have got a part of the superior frontal gyrus, we have got part of the cingulate gyrus, and then a part of corpus callosum that is coming within the frontal lobe itself. So in this picture, you can appreciate this is the precentral gyrus that has been highlighted. All portion anterior to it has been dissected out. This portion will be the part of the frontal lobe. We can appreciate the superior sagittal sinus and the fast cerebral running. We can appreciate these important vascular structures just running over the surface of the corpus callosum. These are callosum marginal artery and pericallosal artery branches of the anterior cerebral artery that run over the surface of the corpus callosum. Okay. So in this diagram, we go in a little bit of detail regarding the various gyri and sulci on the medial surface. You can see that this cingulate sulcus separates the superior frontal gyrus from the cingulate gyrus, and it runs posteriorly and then turns upward. This upward continuation of the cingulate sulcus is known as the ascending marginal ramus. This is also important from radiological point of view. We'll be discussing it later. This ascending marginal ramus is also known as the pars marginalis. So this is the ascending marginal ramus, and the part anterior to the ascending marginal ramus is your paracentral lobule. So if we talk about the boundaries of the paracentral lobule, we know that posteriorly it is bounded by the ascending marginal ramus. Inferiorly it is bounded by the cingulate sulcus. And anteriorly we have got the paracentral sulcus. So these are the margins of the paracentral lobule. And paracentral lobule, anterior portion comes within the frontal lobe, whereas the posterior portion comes within the parietal lobe. Anterior portion has got the representation of the leg area, motor control. The posterior portion has got the representation of the sensory control of the leg area. Then the cingulate sulcus also continues inferiorly as well in this region, where here the part of the cingulate sulcus is known as the subparietal sulcus. So the posterior continuation of cingulate sulcus will be known as the subparietal sulcus. Just posterior to the ascending marginal ramus and anterior to this parieto-occipital sulcus. I told you in the beginning that this parieto-occipital sulcus separates the occipital lobe from the parietal lobe. So bounded by the ascending marginal ramus anteriorly, parieto-occipital sulcus posteriorly, and continuation of cingulate sulcus inferiorly, that is the subparietal sulcus, is the area within the parietal lobe known as the precuneus. Few other structures have been shown in this picture B with respect to the frontal lobe. You can see over here that this is the cingulate gyrus, more clearly demarcated in this picture. When we have removed all other venous structures, the superior frontal gyrus can be seen and the corpus callosum can be seen. You can see that within the corpus callosum, we already discussed we have got the genu of the corpus callosum and the thin sheet of the fibers of the corpus callosum that form the anterior part of the floor and the anterior wall of the lateral ventricle. This region is known as the rostrum of the corpus callosum. Just anterior to the rostrum of corpus callosum, we've got a small gyrus that is known as paraterminal gyrus on the medial surface. Why it is called paraterminal? Because lies just adjacent to the lamina terminalis. And then we have got anterior to it another small gyrus that is known as the para-olfactory gyrus, which lies adjacent to the olfactory tract. That's why it's known as para-olfactory gyrus. These two are again part of the frontal lobe, and these two in turn continue with the cingulate gyrus. The paraterminal gyrus, on the other hand, continues in a thin sheet of gray matter that is known as the indusium griseum that has got a role to play within the limbic system. We can deal with it when we'll be discussing the functional anatomy later on. Okay. In this picture, the deep dissection has been done by the author, and he's going deep to show the relationship of the frontal horn with respect to the frontal lobe. We can see that the most of the frontal horn and the body of the ventricle is actually located in relation to the frontal lobe. Also, the cingulum can be appreciated more clearly over here. In this picture, you can appreciate this pearly white fibers going upwards and running within the frontal lobe. This is actually the area of the corona radiata. Why corona radiata? Because these are radiating, projecting fibers that are coming from the corticospinal tract downwards and traveling over the roof of the ventricle. So in this picture, the medial surface has been shown, but we have drawn various dots across the medial surface. These dots again depict the relationship of the lateral structures with the medial surface. So this dot is actually tracing the central surface on the lateral surface. This is where the central sulcus lies on the lateral surface. And you can see that this is the continuation of the central sulcus on the medial surface, the paracentral lobule, and it runs just in midway between these structures. So this has been highlighted. This is the cingulate sulcus that has been highlighted for you guys. This is the cingulate sulcus, and posteriorly it continues as the ascending marginal ramus and as the subparietal sulcus. This is the paracentral lobule, which has been highlighted. This is the paracentral sulcus, anterior to the paracentral lobule. This is the ascending marginal ramus. So here you can see a picture of an MRI. This is the axial section of the MRI that we have shown over here. Within this, the pars marginalis or the ascending marginal ramus has been shown. So this is the ascending marginal ramus, and this is how it appears on an axial cut. Just in superior views, you can see this bracket-like sign on both sides straddling the midline is the pars bracket that is formed by the pars marginal gyrus or pars marginal sulcus or the ascending marginal ramus. The significance of this pars bracket is that the sulcus that is just anterior to it is the central sulcus. You can see this is the pars marginalis. This is the central sulcus on the sagittal view. Similarly, over here on an axial cut, this is the pars marginalis, and this is the central sulcus. Another method to identify central sulcus is that this sulcus comes all the way to the midline, but does not straddle the midline, does not touch the midline. It stops just short of the midline. So that's how you can identify that which region is the central sulcus. Again, this is important localization of the lesions as the area anterior to the central sulcus is the precentral gyrus, which is your primary somatosensory area. A lesion within this area will affect your motor activity. Another important concept highlight over this inverted Greek letter, that is the omega sign, has been shown over here. This omega sign actually represents the hand knob area. Why called hand knob? Because this area has got the corticospinal nuclei of the corticospinal tracts, which control the movement of your hand. So this is where the hand area is usually represented. We discuss this within the homunculus as well. Other structure, the sulcus that is just anterior to this central sulcus, this sulcus would be precentral sulcus. And this gyrus, which is this sulcus, which is lateral, arranged in an anterior-posterior manner, is the superior frontal sulcus. The part medial to it is the superior frontal gyrus. The part lateral to it is the middle frontal gyrus. And usually we have got a T-shaped sign over here that this precentral sulcus is joined by the superior frontal gyrus in an inverted T-shaped manner. So if I draw an inverted T-shaped manner, it would be like this. That we have this. This is the superior frontal sulcus coming, and then this is the precentral sulcus running over. And this important structure here is the posterior central sulcus. You can see that posterior central sulcus is like a Y shape. So we have got two limbs of the Y, anterior and posterior limb. The posterior limb goes slightly behind the pars bracket, but the anterior limb does not come within the bracket itself, but is just on both sides of this pars bracket. Again, this is the medial surface showing the innermost layer highlighted, that is corpus callosum. Just above the corpus callosum, we have got the cingulate gyrus. In between both of these structures, we have got the callosal sulcus. This is the cingulate sulcus that has been highlighted. This is the parieto-occipital sulcus, which separates the occipital lobe from the parietal lobe on the medial surface. This is again the posterior view where the pars has been retracted on one side and the occipital lobe on the other side, and the parieto-occipital sulcus can be seen over here. And this one is the calcarine sulcus, and in between them, this portion is the occipital lobe. This anterior portion is your parietal lobe, and anterior to it, you have got the precuneus region. So this is the paracentral lobule, which we already discussed, not going into detail. Precuneus has been highlighted in this picture. Now, the final surface is the basal hemispheric surface. So this surface actually rests on the orbital roof. So that's why it has been named as various orbital gyri. We can see that this surface is broadly divided into two parts. This small medial portion, that is known as the gyrus rectus, and this broad lateral portion. They have been divided by this sulcus on the basal surface that is known as the olfactory sulcus. Within the olfactory sulcus, the olfactory tract actually runs. So this small straight gyrus that runs just medial to the olfactory sulcus is known as gyrus rectus. The rectus means straight because it's an straight gyrus, that's why it's called so. And lateral to it, we have got this large orbital gyri, which have been further divided by an orbital sulcus into four parts. It's an H-shaped structure. So lateral to the one straight of H, we have got the lateral orbital gyri. On the medial aspect, we have got the medial orbital gyri. And then we can complete this H, and anteriorly we have got anterior orbital gyri, and posteriorly we have got posterior orbital gyri. You can also appreciate that posterior to this part of the frontal lobe, we have got the central area of the opticocarotid recess and various internal carotid arteries and other structures on the basal surface of the brain. We can trace the sylvian fissure deep within this area. We can see this is the area of the sylvian cistern, and this is the area of the sylvian fissure, which I was talking initially about. Again, the continuation of the relationship of the superficial structures to the deep structure, various dots have been drawn over here. So these dots actually represent where the frontal horn of the lateral ventricle would lie. So if we take away this part of the brain, if we eat it away, we can look that superficial to this area lies the frontal horn of the lateral ventricle. So let me eat it away for you guys. So you can see that I have eaten this part of the brain, and then we can see the lateral ventricle lying deep to this area. So if we remove this layer of the cortex, we can see that genu of the corpus callosum and the rostrum lies just deep to this part of the brain, and it houses the frontal horn of the lateral ventricle. Also, we know that lateral to the lateral ventricle, we have got various basal ganglia, we have got the caudate nucleus, we've got the lentiform nucleus and those structures. Also highlighted over here is an important structure, uncus, that will be discussed in our next lecture when we talk about the temporal lobe anatomy. So now a little bit on the radiological perspective of this whole anatomy that we have gone through. In this picture, you can see an axial cut of the MRI. We have highlighted the pars bracket for you, which I already discussed. This pars bracket represents the marginal sulcus. Just anterior to it, the sulcus that runs all the way to the midline uh, is the central sulcus. So anterior to it, this area will be your motor area. This one would be your primary supratentorial area or the postcentral gyrus. In this picture, again, the T-shaped sign has been shown. You can see that anteriorly this sulcus that is running in an anterior-posterior manner highlighted over here is the posterior frontal sulcus.
Yasir, we can't hear you. Yasir.
Hello?
Ji, we can hear you now.
Better, sir. So this yellow area would be your superior frontal sulcus, and this area would be your superior frontal gyrus. And then this green area, the sulcus that is just anterior to the central sulcus, is your precentral sulcus. So this area is your motor area. Another way to differentiate between the motor area and the somatosensory area, that is pre and the postcentral gyrus, is that the motor area is slightly thicker as compared to your postcentral area. Also, the classical omega sign can be appreciated in this area as well. Now, again, the superior frontal gyrus has been highlighted. Just lateral to it, this portion would be your middle frontal gyrus, superior frontal sulcus, the precentral, postcentral gyrus, just a repetition. The important structure of the posterior central sulcus has also been shown over here. I already told you it's Y-shaped, it's going on both sides of the pars bracket. Various other method to identify the central sulcus. One we went through was that there's this pars bracket just anterior to it. We have got the central sulcus. Another method is the cortical thickness sign. The thickness of the motor cortex is greater as compared to the sensory cortex. Another point is the omega sign. That is the hand knob area is the omega shaped. Another method to identify is inverted T sign, that the superior frontal sulcus actually form the T with the precentral sulcus, and posterior to it we have got the central sulcus. This article from where I taken it, they had also described a white gray sign which showed that if we look very closely, the gray and white matter distinction becomes less distinct around the area of the central sulcus. So this we have already discussed, but let's talk about the medial surface. If we look at the sagittal MRI, on the sagittal aspect of the MRI, the same precentral sulcus, the central sulcus forms a sigmoid hook-shaped sign. So with the help of this sigmoid hook sign, you can identify the central sulcus on the sagittal MRI. So this is the sigmoid hook sign that has been described over here. Again, on the same sagittal MRI, the precentral sulcus has been shown, the central sulcus has been shown, and you can see the inferior frontal sulcus is actually joining the precentral sulcus. So this area will be your inferior frontal gyrus. This is the pars triangularis. You can see the anterior horizontal and anterior ascending lemmas. And this is the inferior frontal sulcus. This will be the area of middle frontal gyrus. And this will be the area of the precentral gyrus. Also, you can trace the Sylvian fissure over here easily. So this is the Sylvian fissure. So again, on the medial surface, we have drawn the cingulate sulcus for you. This is the cingulate sulcus, highlighted by yellow. Its posterior upward continuation known as the pars marginalis. The anterior part to this pars marginalis, the paracentral lobule. The continuation of the central sulcus on the medial surface, and then the superior frontal gyrus. Also, you can appreciate the parieto-occipital sulcus. You can appreciate that area anterior to the parieto-occipital sulcus. This area will be a precuneus. Just anterior to ascending marginal, you have paracentral lobule. So you can all correlate the anatomy radiographically on an MRI as well. So the same structures being highlighted, the cingulate sulcus and the continuation of the central sulcus on the medial surface, the motor area. Okay, now a few cases that I have just described over here. These cases have been placed mainly to localize that which part of the brain is actually involving any specific lesion. So this is a case of a 35 years old male. He had complained of chronic headaches for the last 5 years, underwent the imaging, and then the imaging shown an incidental finding in this case. You can see a lesion over here in this area. Now we can discuss this. I will be going to ask my residents sitting with me over here that which part of brain is affected in this picture and how they can describe that which area this actually is. So can anybody over here, those sitting with me?
So those online can answer in the comment box and we will go through the answers.
First of all, you can describe that which lobe is it? This will be frontal lobe. So then you can identify which part of the frontal lobe. We studied about 3 gyrus anteriorly and a precentral gyrus. Which gyrus does it look to you as? Inferior frontal gyrus. This would be inferior frontal gyrus. Good, because this is the Sylvian fissure. So this area would be of the temporal lobe. Then again, we have got this one running over here. So just anterior to it, this would most probably be the central sulcus. This part will be of your frontal lobe. So this would be the area of your precentral gyrus. This is anterior to it. So we have got superior, middle, and inferior frontal gyri over here. So this is most probably within the region of your inferior frontal gyrus, and more specifically in the pars opercularis probably. So this is a cavernoma that was described. Again, on a coronal cut, the same lesion can be appreciated. You can appreciate the Sylvian fissure over here and lies just above the Sylvian fissure. So it actually forms a wall of the Sylvian fissure. So as we correctly identified, this would be within a pars opercularis, which forms an opercula of your Sylvian fissure. So the next case is about a 43 years old man. He had a history of renal transplant, presented with a fever and altered level of consciousness. Imaging was done. So this is a CT scan imaging, not a good quality image. I'm not going into detail, but you can see a few lesions in these areas. But we have got the MRI of the same patient as well. You can see on an axial T2 screening MR that we have got 3 lesions over here. 2 on the left side and 1 on the right side. So which hemisphere would you localize these lesions to? मतलब, frontal or parietal? So this is the sagittal MRI of the same patient. On one side, this is the lesion. On the contralateral side, these two lesions can be appreciated. So now, okay. So my residents over here describe that all three lesions are within the frontal lobe. I would say they are correct because this is the Sylvian fissure. So this lesion is located within the middle frontal gyrus area of your frontal lobe. Whereas within this area, this one is within the frontal lobe, we can say surely, but here you can see this is the central sulcus. So this would also be within the frontal lobe. They said that this is subcentral gyrus, probably would be, or it would be a part of the precentral gyrus, we can say. Now,
So the online participants are saying that it's frontal and parietal lobe. So do you think it is both frontal and parietal lobe?
no, sir, it's frontal lobe basically because you can see on this sagittal MRI, this is the area of the central sulcus. So this one is located anterior to the central sulcus, not behind it. So this one would be, well, all three lesions would be classified to the frontal lobe. Though this one is on the junction of both, but it still can say that this is in the frontal lobe.
So if anything that is in front of the central sulcus is the frontal lobe. So whenever you're talking about whether the lesion is in the frontal lobe or the parietal lobe, you have to see the central sulcus. And if it is in front, then it's the frontal lobe. Is that what you're saying, Dr. Yasir?
Yes, sir, that is what I'm saying. Agree. So in the third case, I talked about the supplementary motor area within my lecture. So this patient presented with a partial SMS syndrome. She was a 22-year-old woman who underwent an MRI because of seizures. She reported increasing incidence of incoordination, difficulty in typing and walking her dog, resection. The MRI was done of this patient and it showed a lesion within this area. So what area would this be?
So let's start with identifying the central sulcus. Obviously, we've marked it. So this is the central sulcus. It's not coming towards the midline. You can see the omega sign as you already said.
Yeah.
And can we identify the precentral sulcus?
Just anterior to this area, there's a T-shaped sign that is formed over here. So though not very clear in this picture, but this is the area where the precentral sulcus would actually lie. You can see the superior frontal sulcus abutting it in an inverted T-shaped manner. So this is the area of your superior frontal gyrus, and this is the inverted T sign that is being formed. This is your precentral gyrus, and this area would be a postcentral gyrus.
So basically, the
So
supplementary motor area is in front of the precentral gyrus. The precentral sulcus. Is that what you're saying?
yes, sir, that's what I'm saying. This area would be a supplementary or motor area or the premotor area. That is the Broadman area 6. This area is further divided into the medial parts and the lateral parts. The lateral parts deal more specifically with the coordination and planning of the movement, whereas the lateral part of the premotor area actually deals with our eloquent functions like hand activity, speech area, and even the representation of the lower limbs is also within this supplementary motor area.
So most of the participant has got it right. They're all saying that this is the superior frontal gyrus.
Yes, this is superior frontal gyrus, agreed. And this is most likely like low-grade gliomatous lesion within the superior frontal gyrus. So you can see within this picture that a resection of this lesion was performed, and this is where the resection was performed. And again, just anterior to this area, this is the area of your
Dr. Yasir, we have lost your voice. Dr. Yasir, we can't hear you. Can you?
hello.
Yeah, Dr. Yasir, we can hear you now. We lost you in between.
Okay,
Can
sir. Let me go through again. So I was talking about the medial part of the supplementary motor area or the Broadman area 6. This area has got functions of the speech, the fine control or the programming of the upper extremity functions and the lower extremity functions. So this area is located just anterior to your primary motor area. So this would be your primary motor area in this region, and anterior to it, in this area, we have got the supplementary motor area. So this is an example of when a specific MRI, that is bold MRI, which estimates the function of the various motor functions on the basis of the blood oxygen levels. So in this patient, when they all asked him to speak up, this area got highlighted. The signal change occurred in this area. So the speech was within this area. When they asked him to perform fine controls of the upper extremity, this area highlighted. So this is the area where the speech, upper extremity, lower extremity programming is actually located. So if this lesion is to be resected, the patient may present with an specific syndrome that is known as SMA, supplementary motor area syndrome, where the patient can have the deficits related to the mutism, patient can have got upper extremity or the lower extremity weakness. How these areas located? Most anteriorly, we have got the speech area. Just behind it in this region, we have got upper extremity. Most posteriorly, we have got the lower extremity planning. So this is regarding the supplementary motor area. In this specific patient, the patient had speech deficits as when this part of the superior frontal gyrus was ejected out, the patient developed speech deficits. So the case number 4 is of a 52-year-old woman who noticed the third and fourth digit weakness, then had complete loss of the left hand function over 4 to 6 weeks. The functional MR imaging, that is a bold MR imaging, was not done in case, but we got this DTI imaging done. So in this, you can see a lesion over here. Where the lesion would be located, can somebody please help me with this one? My residents over here are describing it as motor cortex. You can all trace this one as the central sulcus. This is the pars bracket. This is the posterior central sulcus, post central sulcus, sorry. And just anterior to it, within this region, we have got the lesion, which is within your motor
so,
cortex.
so everybody online has also gotten right. This is a simple one. Uh,
The why I
so we
have
are
placed
short
this,
on. Yeah. Continue.
why we have placed this MRI is because you can see that this lesion is pushing this part of the sulcus posteriorly. So the area that has been specifically compressed by this lesion deals with your hand activity. I told you about the homunculus. I told you that lower down we have got the control of the facial muscles, we have got the control of the tongue. But over here in this region, the fibers that will be affected will be related to their hand. Similarly, this patient has got deficits of the hand. The hand weakness was present, but the speech weakness,
So Dr. Yasir, your voice dropped again. Please. Uh, Dr. Yasir, we can't hear you. Yes.
just a second. Okay. So this area is the central sulcus. Just anterior to the central sulcus, we have got the precentral gyrus, and anterior to it, we have got this lesion. So this lesion would be within the middle frontal gyrus. This is the area of the superior frontal gyrus. So this would probably be within the middle frontal gyrus. Again, within your supplementary motor area, part of supplementary motor area, which is anterior to your precentral gyrus.
So can you go back, Dr. Yasir? Can you go back to the same MRI that you just showed?
Yeah. So
We can't see your presentation, Dr. Yasir.
Yes, sir. Just give me a second. Can you see it now, sir?
Yes, it is. Yes, it's happening now. Yes, we are on it. So can you go back to the same MRI that you showed? Just wanted to. The
This
other
one?
one, no, this one, yeah. So in the sagittal view, can we appreciate the paracentral? Though this is not a cut, this is a cut which is on the lateral side, not on the medial side. But can we appreciate any sulci on the sagittal view? We can't hear
Are you
you,
asking?
Doctor. Yeah,
Sorry, sir.
yeah, yeah.
Yeah. In this picture, though this is not an accurate appreciate the structures, but we can appreciate these two sulci. I can say that this might be a continuation of the central sulcus probably, and the area over here would be precentral gyrus. And again, this sulcus can be appreciated over here. So though when we come from lateral aspect and we go on to move medially, this area would actually be middle frontal gyrus, as I told you, as appreciated on this scan, and displacing the superior frontal gyrus slightly. So this sulci should go like this one, and then we would have another sulci over here probably. So that's what I think. What are your comments, sir?
So you're right. So I think we are at the end of the presentation. I suggest that if any participants have questions, they can leave it in the question box, and then I'll ask Dr. Yasir to answer those questions. So Dr. Yasir, you can continue, and we'll gather questions till then.
Okay, sir. So again, this case I'm sharing because this has got a lesion on the medial surface and also just abutting the midline. So just close to the midline, we've got this lesion. You can appreciate the cingulate sulcus over here that has been interrupted by this lesion. So this is the anterior portion of the cingulate sulcus. This is the posterior continuation. That is the pars marginalis portion. This is the central sulcus that has been placed on the medial surface. So this lies just anterior to your paracentral lobule, compressing your primary motor area posteriorly, and it's actually involving your superior frontal gyrus, part of your cingulate gyrus, and also displacing the corpus callosum inferiorly. On this MRI, you can see that this area is within your areas which are just located medially, that is within your superior frontal gyrus and within your cingulate gyrus. And though this is not the paracentral lobule, but it has caused a significant compression over the paracentral lobule and has displaced it posteriorly. For these lesions should ideally be approached from an anterior direction in order to save the motor area that will be displaced posteriorly. So again, this lesion is an example of a lesion involving the Broadman area 6 as well, which lies just anterior to your primary motor area. Okay. So again, this is another picture that I've shared. I've shared a lesion over here. Now, this would be question again from the residents that where is this lesion located in this picture? Anybody? Which lobe is it? Just to simplify the things, is it frontal lobe? Which lobe is it? This one is parietal lobe, rightly described by my residents over here. You can see that this one is probably central sulcus that has been traveling over here, and it has displaced the central sulcus anteriorly, and this is a lesion within the parietal lobe. Again, this is an example of an extra axial lesion that can be appreciated on this MR imaging. And though this one is quite easy because we can see that this is within the frontal lobe. Here is where your motor area, here your head knob area would be located. So this is just anterior to the central sulcus, and it's an example of an connectivity meningioma.
Dr. Yasir, you have a last 2 to 3 minutes
Again,
to finish this so that we can take questions.
just finishing it, sir. This is the end of my lecture. So this is the Sylvian. Here you can see it has displaced it inferiorly the temporal lobe and is lying within the frontal lobe. Again, another example of a large lesion with a cystic component as well as a heterogeneous enhancing component that is displacing the interhemispheric fissure and the fast to the opposite side. And where is this lesion located? Can anybody take this? Frontal or the parietal lobe? Frontal lobe, rightly so, though these images are not very clear, but looks to be within the frontal lobe. Where would this lesion be located? Most of the residents over here are saying parietal lobe. I would disagree. I would say this would be occipital lobe. You can see on these coronal cuts going all the way posteriorly. A part of it might be pushing the parietal lobe anteriorly, but this is the occipital lobe that we are dealing with. You can see in this picture very clearly that it is lying just over the tent and then is within the cuneus area of your occipital lobe. So we went through it. So thank you very much for being patient, listening to this lecture.
So thank you, Dr. Yasir, for a great presentation. Obviously, we could see how great you are with your neuroanatomy. So I will open the session for questions. If the candidates have any questions, they can either raise their hand or put a question in the chat box, and we will be happy to answer that question. Till we are gathering questions, Dr. Yasir, what are we going to do next week?
On the next time, we are going to discuss about the same kind of lecture in which we will deal with the anatomy of the temporal lobe, and we will discuss regarding various cases related to the temporal lobe, radiological approach to the temporal lobe lesion. We will also be looking in detail to the lesions of the medial part of the temporal lobe. It is an interesting part of the temporal lobe that can explore in the next session.
So,
temporal in this session, so we will be doing it in the next session. Dr. Yusuf, he's our SR. He will be joining you for the next session, and he will be going through the temporal lobe, radiological and clinical perspective.
So, Dr. Yasir, can you open your chat box and look at one of the questions by one of the candidates? Dr. Noor has asked a question. And please sit close to your laptop so that we can hear you.
The question is that what other imaging investigations can we do prior to the surgical planning of the brain lesions to differentiate the different tracts or the lobes involved other than the MRI with contrast? We can do the spectrography. The spectrography actually is also done on the basis of the MRI, but it actually helps us delineate the various tracts with the help of the diffuse tensor imaging. Some surgeons prefer to go for CT scan, but again, for the brain lesions,
Dr. Yasir, we have difficult. Can you sit close because the candidates have problem hearing you? If you can maybe sit close and
can you hear me now?
Now it's better. It's better. Please speak like what you're speaking like now, so that they can.
Sir, other than the MRI with contrast, the conventional MRI with contrast, spectrography can be done for the planning of the excision of the lesion to highlight the various tracts that are involved. Also, now we have got the functional MRI being done with the help of the blood oxygen level dependent sequences, within which the specific part of the brain that is involved would light up when the specific activity has been performing. So we can actually do the mapping of various activities on the MRI pre-operatively as well.
Dr.
So
Yasir,
these are the other options that.
Though this is not the part of this lecture, but Dr. Mohammed Tahir has requested, can you show cuneus and pre-cuneus on the MRI? I don't know if you have the images, but maybe you can show one of the medial sagittal cut if you have one, and if you can. I mean, it's not a part of this presentation, Dr. Mohammed Tahir, but we will try and show it to you on the MRI. Maybe a medial sagittal cut where you can.
Yeah, we can. Just one. So this precuneus and cuneus can be located on mid-sagittal cut, and if you look at this image, this is the line that is tracing the cingulate sulcus, and this is the ascending marginal ramus. This is the parieto-occipital sulcus. This is the subparietal sulcus. So this is your precuneus, and then again here we would have the calcarine sulcus.
So precuneus is a part of precuneus is a part of which lobe, Dr. Yasir?
Precuneus is part of the parietal lobe. You can see this is the parieto-occipital sulcus. The parieto-occipital sulcus divides the parietal lobe from the occipital lobe, and then anteriorly we have got the ascending marginal ramus and the central sulcus. So this boundary divides the frontal lobe anteriorly from the parietal lobe posteriorly. This boundary divides the parietal lobe anteriorly from the occipital lobe. So the precuneus is bounded by the ascending marginal ramus, the subparietal sulcus, and the parieto-occipital sulcus. Whereas the cuneus is bounded by the parieto-occipital sulcus, and the calcarine sulcus. So this is your cuneus, this is your precuneus.
Thank you, Dr. Yasir. That was an excellent demonstration. Is spectrography better or functional MRI? So, both are, naturally you should have both, Dr. Noor. So if you have a good functional MRI and DTI, you should do both. You do not want to miss on any information. Though DTI is what functional MRI would tell you is it will tell you about your motor, where is your motor area, where is your speech area, where is your supplemental motor area. While the DTI will show you the tracks and it will tell you what tracks are involved, because white matter dissection is important because to have a better outcome.
Sir, thank you very much, sir, for the session. I think now we are out of time. Maybe we can end the session. Do you have some concluding remarks to end the session?
So thank you, Dr. Yasir, for your presentation. And we have started these sessions, and we intend to do this every week. And we have a whole curriculum that we will cover, and during that we will try and orient you guys to the neuroanatomy. And we wish that you all join and spread the word among your friends as well, so that all can get benefit from this great presentations that we are doing. And we are actually doing it for you people. This was actually an in-house session that we used to do, but now we took it online so that we can help others as well. Thank you, Dr. Yasir. Thank you very much.
Yes,
so this
sir.
is the
the next session would be inshallah on Friday, as we have got Muharram processions on the 18th and 19th August. So we will be joining you again on Friday, the 20th August. Thank you very much, Dr. Saad, for your moderation and your support. Thank you, everyone, for joining. Thank you.